introduce you Dr. Rishi Mugesh Khanna from Ganga Hospital, Coimbatore, for our 10th webinar on orthopedic principles. So Dr. Rishi is an international speaker and his area of interest is spine surgery and spinal tuberculosis. So he's going to talk on spinal tuberculosis. Over to you, Dr. Rishi. You can share your screen.
Right. Good evening, friends. Happy evening to one and all. So today I'm going to speak about spinal tuberculosis. This talk will be something like a comprehensive review of the entire gamut of what one needs to be learned about spinal tuberculosis. And I have included some of the current practice guidelines too, so that it benefits everyone right from the experienced orthopedic surgeon who is managing spinal tuberculosis. He gets something like a revision of the entire spinal tuberculosis. And even for the DNB student who is practicing for his exams, he gets a complete clarity of the practices of spinal tuberculosis. So I am here to clear some of the common doubts one would get in managing a patient of spinal tuberculosis. This would include how to evaluate a patient with a suspected port spine. So what are the common investigations that needs to be done? And some of them have the doubt whether MRI findings of spinal tuberculosis, is it reliable or is it enough to start a patient on antitubercular chemotherapy? Or should we do a biopsy in all the patients? And generally what to do after a biopsy, what are the investigations that need to be sent after biopsy. And whenever a patient presents with spinal tuberculosis and a cold abscess in the paraspinal region, should I always aspirate the abscess or should I wait for some more time? Or when to do surgery, and what are the classical indications of surgery? And typically anti-tubercular treatment, this continues to be a raging debate and a confusion for a long time, like how long to give anti-tubercular treatment, and what are the drugs that needs to be given for how long, and a lot of other queries hovers in everybody's mind. So hopefully this presentation would be clearing some of these doubts. So I'll just start with a case presentation. This is a radiographs of a patient, a 34-year-old male who presented with back pain, axial back pain in the lower lumbar region of about 2 months duration, and bilateral weakness in the legs of about 10 days. And he had some constitutional symptoms like evening rise of temperature. We can see the X-rays is pretty much normal, except that you would see some areas of translucency in the vertebral bodies at L3 and L4 levels. But when we did an MRI, the whole spine MRI, the upper part is normal, but in the lumbar spine, you can see there are areas of hyperintense signals in L3, L4, as well as the L5 and the upper part of the sacral region. And in the epidural region also, you can see a lot of collection. Right, in the axial sections too, you see a lot of hyperintense signal changes in the vertebral body, and also there is a epidural fluid collection. So these findings are almost typical of spinal tuberculosis, and in fact, the surgeon who referred the patient to us referred it is a case of spinal tuberculosis, and he has already started the patient on anti-tubercular treatment. But when he did a biopsy, it turned out to be a benign cavernous hemangioma. I'll show another patient. He is a 20-year-old boy who presented with long-standing back pain of about 9 months duration. And as you can see in the MRI, sagittal MRI scan and the sagittal CT scan, there is destruction of the T12 vertebra. There is a complete loss of T12 vertebral body. But instantly, there is no retropulsion, there is no abscess collection, and there is no epidural pus formation. So this is very unlikely of tuberculosis. But when we did the deformity correction surgery and sent a biopsy, he grew Mycobacterium tuberculosis in the specimen. So the thing I want to highlight from these two cases is that in most of the cases, spinal tuberculosis is very easy to manage. The diagnosis is quite straightforward. But there are a lot of cases where there are a lot of mimics which can mimic spinal tuberculosis. And spinal tuberculosis itself can mimic some other diseases like lymphomas and metastases. So we need to be vigilant in these situations. So coming to the basics of spinal tuberculosis, we all know the spine is the most common site for skeletal tuberculosis. So next to the lungs, the skeletal region is a common site for tuberculosis, and among these, spine is the most common site, accounting for about more than 50% of cases. Even though there are more than 63 species in the Mycobacterium genera, Mycobacterium tuberculosis is the commonest species that causes spinal infection. And within the spine, it has a predilection to affect the thoracolumbar region. And there are a lot of theories for this predilection, the high vascularity of the vertebral marrow, as well as to the proximity of the vertebral region to the structures such as cisterna chyli, kidneys, lungs, which usually serve as the primary focus of the tubercular bacilli. So from these, the bacilli easily gets transferred to the thoracolumbar region. So this is the latest 2019 World Health Organization's Global Tuberculosis Report. So there are almost 10 million new cases of tuberculosis and 1.2 million people die due to the disease every year. So as per today's statistics, we have 170 deaths due to corona infection, but tuberculosis causes more deaths every year. 1.2 million people die due to every year. And India is one of the 8 countries which account for more than 3/4 of the world's total tuberculosis infections. So we are harboring a large amount of patients with this tuberculosis. And among these, the interesting fact is a lot of patients can have a drug-resistant tuberculosis, because this is a sinister issue, because only 56% treatment success rate is possible in these patients. So all this is because of this Bacillus Mycobacterium tuberculosis, which has an unique microbiological structure and function. So it has a high lipid and peptidoglycan rich cell wall, which prevents the normal antibiotics to penetrate. It also makes this bacteria resistant to be digested by our macrophages. So it resists immunity and resists the common antibiotics. And it is also a very slow growing organism. Only when the bacillus multiplies, the antibiotics work effectively. When it is a slow growing dormant organism, it is difficult for the antibiotics to work on these bacillus. So these all explain why TB is difficult to diagnose, treat, and eradicate from our planet. So what happens whenever the bacillus enters the system? It usually causes a primary focus elsewhere in the body. The spine is usually not the primary focus. There is a focus in the lungs, kidneys, or the lymph nodes. From there is a hematogenous dissemination of these bacillus, which enters into the lungs. Other modes of spread include the Batson's paravertebral venous plexus from the pelvic organs, or sometimes contiguous spread from the paraaortic lymph nodes also exists. The moment the bacillus enters into the vertebral marrow, it is digested by the macrophages, but they are not able to completely digest it. Soon the macrophages get transformed into epithelioid cells. So these epithelioid cells are nothing but modified macrophages. Sometimes in these tubercles, the macrophages coalesce to form Langerhans giant cells. Caseation necrosis due to coagulation through proteolytic enzymes results in the formation of this tubercle. So this is very important. The combination of this caseating necrosis, epithelioid cells, and Langerhans giant cells is considered as the hallmark feature of tuberculosis, by which may be confirmed the diagnosis of tuberculosis. So once this is the microscopic anatomy. So in the macroscopic anatomy, once the bacillus enters through the arteries, usually the spinal blood vessels have an unique anatomy. So you can see the blood vessel reaches near the disc, and then it bifurcates on either side of the disc. So bacilli which enters through this blood vessels reach on either side of the disc. So once they reach either side of the disc, there is a subchondral infection. The vertebral disc is usually an avascular structure, so usually it is not affected in the initial stages of the disease. But once the bacillus starts eroding the subchondral bone, there is a contiguous spread, the disc loses its nutrition, and then slowly it also gets affected. So progressive destruction of the bacilli, which results in osteolysis. There is an increased vascularity because of the chronic inflammation, so there is osteoporosis. And these bacilli also start occluding the small arterioles of the vertebral body. So there is osteonecrosis. So these three factors, osteolysis, osteoporosis, and osteonecrosis, all three are responsible for vertebral body collapse, which typically occurs in spinal tuberculosis. So soon there is collapse of the disc space, there is exuberant abscess formation. So these three factors together contribute to the local kyphosis, which is typically seen in spinal tuberculosis. So these factors are responsible for the spinal cord compression and neurological deficit, which ensues in spinal tuberculosis. So this what we described now is called as the typical paradiscal type, which is the most commonly seen in spinal tuberculosis. But there are three other types of patterns of spinal tubercle infection. There's a centrum type. So the centrum type is where one vertebral body is typically affected. There is no adjacent vertebral body involvement. So this is typically seen in young children. The rarer types are the posterior type and the non-osseous type. So posterior type, predominantly the posterior elements of the spine. There is the pedicle, the facet joints are affected. The non-osseous type is very unique. So you don't see any vertebral destruction in the radiographs, but you see exuberant abscess formation everywhere in the spine. So these are some typical examples. Those are the paradiscal type. This is a centrum type. As you can see, one vertebral body is completely destroyed. So this is the posterior type. The spinous process affected by tuberculosis. And this is the non-osseous type. So as you can see, the bones appear completely normal, but there is a huge abscess formation within the iliacus muscle. So coming to the clinical features, there are 5 classical clinical features of spinal tuberculosis. The first and most common is the axial pain. So all patients will have pain somewhere in the axial skeleton. It's very rare for a patient with spinal tuberculosis to present without pain. Next is the constitutional symptoms. Third is the paravertebral abscess or the cold abscess formation. Fourth is the vertebral deformity, there is kyphosis. And fifth one is the neurological deficit. So we'll see one after the one. So before going into the 5 symptoms, I would like to highlight this point. So tuberculosis is a systemic disease. So even though you see one area of the spine is affected, you have to get a whole spine MRI because some of these patients will have skip lesions. Some of these patients have skip lesions in almost 70% of the patients when we do a whole spine MRI. So the symptoms will be related to one particular region which is more affected, but there will be lesions in rest of the spine too. For example, this patient had lesions in 2 regions of the spine, as well as she also had a pleural effusion. So we have to be cognizant of this fact. So coming to the clinical features, like I told, axial pain is present in almost all patients. So if it is the thoracolumbar region, back pain is a common symptom. There are usually 3 types of pain which occurs in spinal tuberculosis. So in the early phase, it's only inflammation. So the patients usually get a nagging type of pain. Some of the patients have a lot of abscess formation. So when the abscess starts distending, they develop an aching type of pain. When there is a pathological fracture due to the vertebral destruction, they get a severe pain which results due to spinal instability. Another thing which is very typical of spinal tuberculosis is the night cries. So during the night, when the protective muscle spasm relaxes, there is rubbing of the raw inflamed bone which results in sudden increase in the pain. So the patient has to get up from get up from sleep because of this pain. Another thing, this tripod sign is characteristically explained in tuberculosis. So some of the patients, when they develop gradual instability, they use their own hands to support their neck. So this is typically seen in cervical tuberculosis. So this child had a CV junction tuberculosis. So she has to continuously support her neck with her own hand. And if they have a thoracolumbar instability, they use their own hands to support their lower body. So this is called as a tripod sign. Constitutional symptoms, unlike pulmonary tuberculosis, constitutional symptoms is not very typical of spinal tuberculosis. Only less than 40% of the patients have constitutional symptoms. This is especially common in patients who are well fed. So if they are well fed, they are economically and socially on the higher strata, they may harbor the spinal infection, but they will not have any constitutional symptoms. So those patients who are malnourished, they present more with loss of weight, appetite, evening rise of temperature in patients with spinal tuberculosis. The third thing which I told is the paravertebral swellings or the cold abscess. They are almost diagnostic of tuberculosis. So if you see a patient with an axial pain and a cold abscess in the paraspinal region, it is more likely to be spinal tuberculosis. The interesting thing about these abscesses is that the place where they form in the skin is not the place where they are originating in the spine. So they track through various planes like perineural, perivascular, intermuscular, subpleural and the retroperitoneal planes, and then through these planes they present somewhere distally. For example, psoas abscess which starts in the Thoracolumbar region can present in the gluteal region, or it can track through the psoas muscle and present in the inguinal region too. So these abscesses, if treated adequately early in the stages of the abscess formation, they are very well amenable to be treated by antitubercular treatment. There is no need to aspirate these abscesses. But if left untreated and where they are very superficial, these abscesses may rupture and they can result in sinus formation. So we've seen loads and loads of abscess. For example, this patient has a huge abscess in the gluteal region bilaterally. He has an abscess in the presacral region. He has an abscess in the right iliacus. He has an abscess in the left iliacus. And this patient was not aspirated, and with complete antitubercular treatment, it completely resolved. The fourth symptom is kyphosis. Kyphosis is inevitable in spinal tuberculosis. The grade of the or the degree of the kyphosis can vary depending on the extent of the vertebral destruction. But kyphosis is inevitable because tuberculosis typically affects the anterior part of the vertebral body, and healing of the disease happens by fusion of two adjacent healthy bones. So when there is a fusion of two adjacent healthy bones, some amount of kyphosis is bound to occur. So if there is single vertebral body affliction, you can have a knuckle type of deformity. If 2 or 3 adjacent vertebral bodies are involved, you can have the gibbous deformity, and multiple vertebrae are involved, you call it as a rounded kyphosis. The fifth symptom is a neurological deficit. It occurs in about 20% of the patients. The interesting fact about neurological deficit in spinal tuberculosis is that it can happen both in the active as well as the late stages of the disease. So healed stages also, the patient can present with neurological deficit, which needs to be explained to the patient also. So in the active stage, as we discussed earlier in the pathophysiology, the exuberant abscess which forms around the spinal cord, the inflammatory granulation tissue, what is called as a dry abscess, which compresses the spinal cord, and where there is a pathological fracture resulting in retropulsion of the bone. So that also causes neurological deficit. Sometimes there is only abscess formation and there is spinal instability. The bone starts subluxating forward. Typically, this is seen in children. So these patients also develop acute stage neurological deficit. In late stages, when the deformity exceeds more than 70 or 80 degrees of kyphosis, the spinal cord gets stretched over a bony ridge at the apex of the deformity, and the patient slowly starts developing a neurological deficit. So whatever we saw in the earlier slides, I'll just to summarize. So the 3 hallmarks of spinal tuberculosis in the histopathology is epithelioid cells, Langhans cells, and cacheation. Disease starts in the subchondral region in most commonly, and then it progresses to affect the disc and the vertebral bone. Progressive destruction results in collapse and abscess, resulting in the 5 typical clinical features which I summarized earlier. So now we know that there is a patient with a possible spinal infection. How are we going to evaluate the patient? What are the standard tests that needs to be done? Is there a reliable validity with these tests? So spinal tuberculosis diagnosis is one where we need to use a combination of all these 4 things to confirm the diagnosis. It's not only based on clinical features, lab investigations, microbiological investigations, and radiology alone. All these features individually have their own significance. You take everything together and then come to a diagnosis. Coming to the first investigation, which is commonly done, erythrocyte sedimentation rate, ESR, and total cell counts. So both these things are usually elevated in spinal tuberculosis. So we can say this is a highly sensitive test, but they are not very specific. So they are common for any infection, any chronic infection. So we can't say just because these are elevated there, it is a case of spinal tuberculosis. So what is the real value of ESR? So serial ESR measurement is very useful to assess the response to treatment. Normally after a patient takes antitubercular treatment for 3 months, it should normalize. So if there is a failure to normalize, then we need to consider an alternate diagnosis, or we need to repeat the biopsy. Similarly, the total and the differential lymphocyte counts too. C-reactive protein, again, it is commonly done in any patient who presents with a spondylodiscitis. Again, it's useful to differentiate acute infection, acute pyogenic spondylodiscitis from a chronic infection, but it doesn't pinpoint that this chronic infection could be due to spinal tuberculosis, because in a lot of patients, even with chronic infections like spinal tuberculosis, that could be a rise in CRP levels. Liver function test, it's absolutely mandatory. It has to be done in any patient who is likely to be started on anti-tubercular treatment, because a lot of drugs are hepatotoxic. So you need to know the pre-chemotherapy status of the liver. Coming to the next test, which is commonly performed, Mantoux test. So Mantoux test falls under a group of tests called immune response test. This basically assesses a person's ability to mount a lymphocyte-based immune response. If the patient has previously exposed to spinal tuberculosis or any pulmonary tuberculosis, there will be a positive test. It doesn't mean that the patient is having an active infection. So in non-endemic regions like Europe or Northern America, this has a value. But in endemic regions like India, this doesn't have a value. Similarly, the second type of immune response test, I have seen a lot of prescriptions where the patient has undergone this test, QT-Ferron TB Gold test. So this is also assesses whether the patient has been previously exposed to tubercular antigens. It will be positive in most of the patients in endemic regions. That doesn't confirm the diagnosis of active spinal tuberculosis. The last one, ELISA test for antibodies. Again, a lot of labs do that, but the WHO has banned the use of tests in patients with spinal tuberculosis. It should not be done. So what is the consensus on laboratory tests? We do hemoglobin TCDC ESR for a basic baseline assessment and liver function test also. If the patient is from a non-endemic region, you can do a Mantoux test or an interferon gamma that will help in confirming the diagnosis. You should not do IgM, IgM antibodies, ELISA test, and a blood PCR test also. Blood PCR also doesn't have any role in diagnosing spinal tuberculosis. So coming to the radiology, the standard tests performed are radiographs and MRI. Radiographs, as we all know, they take some time for the radiographic changes to take, at least 3 to 4 weeks. But spinal tuberculosis being a chronic infection, most of the patients, by the time they present to us, usually have some radiological changes. So these are considered as the early features of spinal tuberculosis. Vertebral subchondral osteoporosis. You can see some areas of translucency closer to the region which is affected. There will be narrowing of disc space. So as the subchondral marrow collapses, slowly the disc loses its vascularity, so there will be narrowing of disc space. And the vertebral margins also become indistinct. Okay. And you also look at the soft tissue shadows. This is very important in spinal tuberculosis. So this patient has a lesion at the level of the lower thoracic region, and you can see a prominent soft tissue shadow around these regions. So this is called a bird's nest appearance. So this is typical of spinal tuberculosis with cold abscess formation in the paraspinal region. Late features are very diagnostic. So once this patient presents at this stage, it's easy to make a diagnosis. So you have a vertebral collapse of 1 or 2 vertebra. Sometimes you can appreciate the severity of kyphosis. There may be lateral translation. So at this stage, the patient will develop spinal instability also. There could be asymmetrical wedging of the vertebra. So if one vertebra or one disc space is more affected, there will be asymmetrical wedging, and you can see a slight scoliosis at this stage. And this finding is typically seen in children. So this is called as the aneurysmal phenomenon. Just like a patient with an aneurysm of the aorta slowly develops erosion of the vertebral body. If there is an abscess formation beneath the anterior longitudinal ligament, there will be erosion of the anterior surface of the vertebra. There will be scalloping will be seen. So this is called as aneurysmal phenomenon seen in spinal tuberculosis. CT scan, usually we don't do in all the patients. It is done in patients where the surgery is planned. So to see where all the pedicle screws needs to be applied, we do a CT scan. In some regions which are usually not well seen in the radiographs, like the craniovertebral junction or the cervicothoracic junction, we do a CT scan, or we straight away go for an MRI scan. In some centers, they do a CT guided biopsy. So these are the 3 areas where you find some role for the CT scan in spinal tuberculosis. MRI, I would say this is the gold standard radiological investigation. So whenever you see a patient with possible spinal tuberculosis, really you can have a very low threshold of doing a MRI scan, because it helps in early diagnosis. Because you start the treatment early, you can have better results. And there are some 3 or 4 telltale signs which are present in the MRI, which can really help you to make a diagnosis of spinal tuberculosis with reasonable confidence. So these include a well-defined paraspinal signal, a thin and smooth abscess wall. So we did a study recently of about 150 patients of spinal tuberculosis, and we found that a patient with a thin, smooth abscess wall, subligamentous spread, and a vertebral collapse more than 50% had a very high chance of having a positive spinal tuberculosis. Similarly, intraosseous abscess and presence of involvement of multiple vertebral bodies. So these are also classical signs which indicate this could be a case of spinal tuberculosis. The other advantages, it also helps in planning the treatment. So extent of the disease within the soft tissue. So if you're planning to do a decompression, from where to where should I do the decompression? And after a period of anti-tubercular treatment, you want to assess the response to treatment. You do an MRI after 6 months. You can compare the MRI before treatment and after treatment to see how much has the pus has abscess has been resolved and how much of the cord compression has been resolved, and is there any signal changes within the spinal cord. All of these are helpful in assessing the treatment response. And finally, currently MRI is a standard investigation done to confirm the healing of the disease. So we do an MRI at 9 months to one year after starting anti-tubercular treatment to assess the complete healing of the disease, based on which we can stop the anti-tubercular treatment. This is as equivalent to having a sputum negativity in patients who is having a pulmonary tuberculosis. So final test is the tissue analysis. So tissue analysis is done by doing a biopsy. I would say biopsy is as equivalent as or even more important than having an MRI alone. So once a patient has an MRI and you are reasonably sure that this patient is having spinal tuberculosis, this patient has to be subjected to biopsy and tissue tests for some important reasons. Once you take the biopsy tissue, you send it for 3 different tests. One is the tubercular culture, the second is the gene expert test, and third is the histopathological examination. So the importance of TB culture, it confirms the diagnosis. So this is like a 100% confirmation. If you grow a tubercular bacilli, live tubercular bacilli, 6 weeks of after intubation, then you are 100% sure that the patient is having active spinal infection due to tuberculosis. The second advantage, it helps us to acquire antibiotic sensitivities. So around 5 to 10% of the patients can have drug resistance. If you have an antibiotic sensitivity, it helps you to guide the appropriate therapy for the patient. But this infection is usually a paucibacillary infection, so it's very difficult to get a suitable tissue in which the bacteria is live and in more numbers so that it will grow in a culture media outside. So try to get as much amount of culture material as possible from different areas like bone and abscess walls. There is something which has revolutionized the management of or investigation of spinal tuberculosis, that is gene expert test. The gene expert test again is done in the tissue which we take from a biopsy. The advantage of this test is you get a immediate result within 90 minutes. So this is based on polymerase chain reaction. Second advantage of this test is it also gives us an indication of the presence of drug resistance. So if they can find genes which are indicative of rifampicin resistance, based on which we have an idea. So a lot of studies have shown more than 90% sensitivity and specificity with gene expert test to be done mandatorily. And finally, we also do a histopathological examination, as I told, cacheation necrosis, Langhans giant cells, epithelioid cells. If this combination is present, this is diagnostic of spinal tuberculosis. So coming to the question, should we do a biopsy for a patient with suspected spinal tuberculosis? I would say it is mandatory. Please do it, because we rule out MDR, we rule out other diseases. I have seen a lot of patients like classically described as tuberculosis in the MRI, but when it did a biopsy, it turned out to be a lymphoma. It has turned out to be a metastasis. So when we do a biopsy, usually we don't do a CT guided biopsy. Preferably we do a C-arm guided biopsy under anesthesia, because this helps us to have a bigger chunk of tissue with a bigger Jamshidi needle. So we use a 8 or a 10 millimeter, 10 French size Jamshidi needle. And we are able to take multiple passes through the pedicle into the disc, into the abscess, into the bone, so that we get a lot of tissues. And the other common query people pose is, should we need to stop the anti-tubercular treatment before biopsy? Not necessary. If the patient has already been started on anti-tubercular treatment elsewhere, you can still do the biopsy. So is there any instance where we don't do a biopsy? Yes, if the patient is already is a known case of tuberculosis, like a classical pulmonary tuberculosis, was in confirmed sputum positive on anti-tubercular treatment and comes with an MRI which shows a lesion in the spine, then we don't need to do a biopsy. And the WHO has endorsed this thing that in places where the resources are poor to get a biopsy, and then the patient has a classical clinical radiological presentation, clinical symptoms typical of tuberculosis, and MRI also typical of tuberculosis, you can start the patient on empirical anti-tubercular treatment for 1 month, and if there is a response, continue the same treatment. If there is no response, you have to send the patient to a center for a biopsy. So this is only in places where the resources are inadequate. So in summary of the diagnostic part, so radiographs are the first line of investigation, but they diagnose the disease late. So I have a low threshold to have a MRI done. And when you do an MRI, try to have a whole spine sequence too to identify skip lesions, because MRI helps in assessing the treatment response also. Biopsy is essential as discussed earlier. So coming to the final part of the presentation, how are we going to manage a patient? So you have clinically assessed them, you have done radiograph, you did basic blood investigations, you didn't do the ELISA test, you didn't do the IgG, quantiferin gold, you didn't do the tuberculin test. All those tests are not going to help us in an endemic country like India. But you did an MRI and you have done also a biopsy to confirm the diagnosis. Now the biopsy diagnosis is confirmed. How are you going to manage the patient? So first thing, this is the like a biblical rule. Anti-tubercular chemotherapy is the mainstay of treatment of spinal tuberculosis. Whether you are going to do surgery, you are going to do a radical debridement or not, tubercular chemotherapy is the mainstay of treatment. So what are the classical surgical indications? So the surgical indications, there are no strict absolute and relative indications. Different centers have a different guidelines, but this is something like a standard protocol. Again, the three factors which we discussed earlier: neurological deficit, severity of vertebral damage, and kyphosis. These three things determine the need for surgery. So if the patient presents to you at the first time with gross neurological deficit, paraparesis or paraplegia, surgery is advised. If the patient is having a new onset or a deteriorating deficit after the start of treatment, then surgery is advised. And in the MRI, if there is a dry lesion with a neurological deficit, again, there is no point in waiting. Try to do surgery as early as possible. Then second thing is severity of vertebral damage. If there is a pan-vertebral disease, completely one vertebral body involvement is there, there is destruction extending up to the pedicle, then there is a potential source of gross deformity. Surgery is advised. Spinatus signs in children. There is more than 2 spinatus signs which will indicate a gross progression of deformity later on, even after the disease is healed in this child. These children are prone for kyphosis. So these children need a surgery. And pain. Pain is slightly like a relative indication. So there is lack of improvement in pain after 6 weeks of bed rest, bracing, and chemotherapy. The patient continues to have pain. Surgery may be indicated. If there is spinal instability in the radiographs, there is spinal instability pain correlating with the radiographs, surgery is advised. Kyphosis, if there is more than one vertebral body involvement, or if there are 1 or 2 vertebral bodies contiguously involved and the kyphosis is exceeding 30 degrees, surgery is advised. In late deformities, where there is severe kyphosis more than 60 degrees with or without neurological deficit, then one would advise a surgery. So if you look at the evolution of management of spinal tuberculosis, it's actually a really interesting story. So you should read some of the original articles published by Hodgson et al. So before 1960, treatment of tuberculosis was gloomy. So there was significant morbidity and mortality because the chemotherapy agents were not available then. From 1960s to 1970s, you had all 4 primary anti-tubercular drugs available. So once these drugs were available, the disease control was excellent and a lot of patients started to have excellent results. But still patients who presented late had kyphosis and neurological deficit. So what Hodgson did, he popularized the concept of radical anterior surgery. So he started the anterior surgery for spinal tuberculosis through a transthoracic or a retroperitoneal approach and completely debrided the lesion. So whatever bone he thought is infected, he completely debrided the lesion along with chemotherapy. So he showed excellent results through radical excision of the diseased tissue. So the problem was that the more radically the bone was excised, they found it difficult to reconstruct the defective anterior column. So the presence of modern spinal instrumentation was not available then. So just the long rib grafts which were placed in 2 or 3 vertebral defects couldn't support the stress of the spinal bone, and these grafts started pulling off and breaking, which resulted in a lot of complications. So a lot of people were not able to reproduce the results given by Hodgson. Then came out Professor Tully. So he described the middle path regimen. So he advised initial period of conservative management for almost all patients, and surgery was indicated only for select situations. And he reported excellent results because we don't need to radically excise the disease. Antitubercular chemotherapy has excellent penetration into the abscess wall, and the tissues, bone tissues. So he described surgery only for select situations. So this is also the current concept. If there is an uncomplicated spinal tuberculosis, it is treated as a medical disease. So combination chemotherapy, the important thing is the appropriate duration and adequate dosage. So based on body weight, it has to be given, and make sure that the patient is compliant taking the medications. So if this is given, most of the patients will have very good results. Why combination chemotherapy and why we are giving for a long duration? Because of the unique microbiological features of the tubercular bacilli. So as explained earlier, a lot of antibiotics cannot penetrate the mycobacteria because of its thick cell wall, and it is also a slow growing bacillus. Even in the most favorable conditions, it replicates only once in 24 hours. But in unfavorable conditions, it remains dormant. So you need different kinds of bacteria, antibacterial agent, which works on different growth kinetics of the bacilli and metabolic characteristics. For example, some of these drugs are bactericidal, some of them are bacteriostatic, some of them act extracellular, some of them act intracellular, some of them act even inside the macrophages too. So we need a combination drugs to kill all types of bacilli present in the microbiological colony. That's why we give 4 drugs and in different phases of treatment. So these are the typical 5 first line drugs: isoniazid, rifampicin, pyrazinamide, and streptomycin. The most important thing is to give it the appropriate dosage. So 5 milligram per kg body weight is the standard dose of isoniazid. Patient's body weight should be measured and then prescribed accordingly. And these are the second line drugs. Second line drugs are typically used in patients with drug resistance. So this is the current standard TB guidelines. So there's a lot of confusion against the duration of antitubercular treatment and what drugs to be given. So this is a 2016 guidelines published by the DOTS and supported by the World Health Organization. These are the guidelines for extrapulmonary tuberculosis. So this is the daily treatment regimen. There is no weekly thrice regimen. It is a daily treatment regimen. And drugs are given in the standard intensive phase and continuation phase. So intensive phase, we give it for 2 months and 4 drugs: isoniazid, rifampicin, pyrazinamide, ethambutol, to rapidly destroy the majority of the organisms. This is followed by a 10-month course of continuation phase where we give 3 drugs. So previously used to give only 4 months and 2 drugs. So now it is 10 months, 3 drugs: isoniazid, rifampicin, and ethambutol, to kill all the slow multipliers and the dormant bacilli. But they have added a caveat at the last. So patients' treatment has to be individualized. So at the end of 12 months of treatment, if you see the patient has not fully resolved from the disease, if there is an evidence of residual disease, then treatment can be individualized and continue till up to 18 months also. So how are you going to monitor the response to treatment? So started the patient on antitubercular treatment. How do you know whether he is responding or and not developing any side effects due to the drugs? So usually by 6 to 8 weeks, the patient regains his appetite and start putting up weight. So every time you see the patient, we see the patient every 6 weeks. So the patient should put up weight every 6 weeks. Spine pain and muscle spasms should reduce. ESR takes at least 4 to 6 weeks to show a demonstrable change. And by 3 months, there should be normalization of ESR from the baseline values. Radiographs. So you do radiographs, and by the 3 to 4 months only, you see some demonstrable, perceptible change in the healing of the disease. So the abscess shadows should reduce in size. There should be sclerosis of the bone. Wherever we saw osteoporosis, there should be sclerosis of the bone. And at the healing of the disease, there should be complete bony fusion. That this upper vertebra should fuse with the lower vertebra. MRI signs of healing, this is also important. Based on this only, we stop the anti-tubercle treatment at present. So we do an MRI at the end of 9 months and 1 year. We look for resolution of marrow edema, resolution of complete paravertebral abscesses, and the marrow fat in the vertebra should be seen as a bright signal. So the red marrow gets completely replaced by fat. It will be seen as a bright signal in T1 weighted images. So this is a patient who presented at 0, 6 months and 9 months. We have an MRI. So you can see a lot of abscess. So it is a typical L4-5 tubercular spondylar discitis with a huge prevertebral abscess. So you can see all the telltale signs of a spinal tuberculosis. There is AZ, vertebral margins, there is reduction in disc space, and areas of translucencies is seen. So at 6 months, you can see there is areas of sclerosis. Areas of sclerosis is seen, and the abscess is started to reduce in size. And at 9 months, you don't see any abscess. And this is just a thickened anterior longitudinal ligament. And you can see complete bony fusion between L4 and L5, which indicates that the disease has completely healed. So coming to surgical treatment, we already discussed the typical indications for surgery. So the goals of surgical treatment are mainly 3. So we are planning to decompress the spinal cord, we have to correct the deformity, and we have to provide stability to the spine. So whatever surgical treatment we are going to give has to serve these 3 goals, either alone or in combination. So what do we mean by decompression? So if the patient is already having a neurological deficit, so we debride and drain the abscesses in the prevertebral and epidural region. And if there is any bony compression, so due to a sequestrum or a pathological fracture, we decompress the cord, remove the bony compression. And these patients, whenever there is a pathological fracture, they will have kyphosis. So we correct the deformity by putting pedicle screws. So these pedicle screws also provide stability. So whenever you decompress the spinal cord by removing the destroyed bone, there is an anterior void. So this void either can be filled with bone grafts, or also you can put a artificial titanium cage. So the use of these materials in an infected patient has been proven to be very well safe in multiple studies. So the tubercular bacilli doesn't form a biofilm over the titanium implants. So we should not be scared to put a pedicle screw or a titanium cage even in an infected bone. So that helps in actually healing the disease. So these 3 goals are achieved by 3 different surgical approaches. One is this anterior approach. Second is a combined anterior and posterior approach. And third is an all posterior approach. So as we learned that tuberculosis is an anterior disease. So the vertebral body is the one which is predominantly affected. So if you are going to tackle the disease in its place, so you have to do an anterior surgery. So anterior surgery offers the advantage of direct access to the disease region. You can visualize the spinal cord, completely decompress the cord, and you can place strut grafts. So removal of the foci up to the bleeding bone is enough, and chemotherapy is efficient in clearing the rest of the residual infection. But one problem with the anterior approach is in the thoracic and in the lumbar region, these patients already will have a compromised lung function, and they also will have a malnutrition. So these approaches tend to be very morbid and difficult for the patients to go through. But in the cervical spine, there is no contraindications like this, and this is the preferred approach. So whenever the patient presents with cervical tuberculosis, we preferably do the anterior approach. And in rare situations in thoracic and thoracolumbar region, we do the anterior surgery. So this is a typical example. This is a patient, a 45-year-old male who presented with a lesion in the C7 vertebra. So you can see there is partial destruction of the C7 vertebra. So this is a junctional region. So if you're not able to see properly in the radiographs, you have to do a CT scan or MRI scan to see the bone clearly, and you can see the spinal cord is also compressed. There is abscess formation here, which is compressing the spinal cord. So this patient presented with neurological deficit, hence we did a anterior debridement, and we have put a cage and then supported with a plate. So this patient will also be treated with antitubercular chemotherapy simultaneously. Combined approach, this was popular about 5 to 10 years ago whenever the patient is having excessive vertebral destruction and kyphosis, where one surgery alone will not suffice. So what the surgeons used to do is do an anterior decompression as a separate approach and then support the posterior spine through a separate posterior pedicle screw fixation. But as I said, these are all patients who have a compromised immunity, compromised systemic environment. So in these patients, it's difficult to tolerate two surgeries. So these combined surgeries are almost obsolete now. So this is an example, a child who presented with multi-level tuberculosis, extensive abscess formation. So you can see abscess formation extensively. There was a cord compression. So this is the spinal cord completely compressed by the exuberant abscess formation and granulation tissue. So with this granulation tissue and compression, the patient need a combined surgery. So complete excision of this vertebra to decompress the spinal cord will be a bigger surgery for this child. So hence after debridement, we had put a fibular bone graft and then supplemented posteriorly with the posterior pedicle screw fixation. So the current standard of surgical care for patients with spinal tuberculosis seems to be the all posterior approach. So through a standard posterior approach, whatever needs to be done through an anterior surgery, we are able to do it by a posterior approach. So first we expose the spine through a posterior midline approach, fix the spine with pedicle screws to provide stability, then access the anterior part of the spine through either a transpedicular route or a transforaminal route. We reach the anterior part of the spine, curate all the infected tissue, and then either a cage is placed or we can pack it with bone grafts. So this provides stability. This enables us to reconstruct the anterior column also. The advantages of these post approaches, surgeon is familiar with the approach. So everybody can do this approach. It's not necessary to have an access surgeon or adequate experience to do an anterior surgery. So it provides an excellent exposure for a circumferential spinal cord compression. So you can see the spinal cord 360 degrees, which sometimes it's not possible even with an anterior surgery. If there is a need to extend the levels, it's easy to extend the levels in a posterior surgery compared to an anterior surgery. And the amount of stability you get with the pedicle screws and rod system is much better to do a good solid deformity correction. So as I said earlier, a lot of these patients have compromised lung function. So all these posterior approaches are extrapleural, so they don't affect the pulmonary function of these patients. So this is an example. He is actually a young boy, about 12 years old, who presented with L1, L2 tuberculosis, and completely you can see the bone is retropulsed and the conus medullaris and the cauda equina are compressed. The patient presented with a neurological deficit. So we have done a posterior fixation, debridement, and as you can see, this is the follow-up radiograph. There is complete healing of the disease. So this is another patient. It's a centrum type of tuberculosis. The T1, 2, 3, T3 vertebra is completely affected, and you can see there is some retropulsion and cord signal changes is also present. The patient presented with a neurological deficit. So this T3 region is very difficult to access anteriorly. And as you can see, we have done a posterior fixation from T1 to T6. And through the posterior approach, we have debrided the anterior infected part and placed a titanium cage also. So we have reached the final stage of our presentation or talk. So we comprehensively evaluated. We saw the epidemiology, the basic pathophysiology of the disease, how the disease starts in the subchondral regions, affects the other parts of the vertebra, the disc, how the abscess forms, and what are the classical 5 clinical symptoms, and how do we evaluate a patient, what is the role of blood test, what blood tests to be done, what should not be done, what are the classical radiological X-ray findings, and MRI should be done as a low threshold level, and as far as possible, biopsy and tissue analysis has to be done. Once the diagnosis is confirmed, medical management is the key. The standard guidelines now is for 12 months, 2 months of intensive phase and 10 months of continuation phase, 4 drugs initially and 3 drugs in the continuation phase. How are we going to follow the patients? I told by hematological, clinical and radiological assessment, and surgery has selected indications. So you put the patient in 3 blocks, whether the patient is having a severe deformity, where there is severe vertebral destruction, and where there is neurological deficit. Based on 3 blocks, if the patient fills in one of these blocks, then surgery may be advised. And there are different surgical approaches. Current standard of care for cervical spine, preferably anterior surgery, and for thoracic and thoracolumbar and lumbar region, we follow the posterior surgery, because posterior surgery is easy to do, gives very good results, and unlike a tumor surgery, you don't need to do a radical excision in spinal tuberculosis. So only the key infected part and the dead tissue are removed, and rest of the infection is taken care by anti-tubercular chemotherapy. Plus following it up with MRI at the end of 12 months to assess the complete healing of the disease, and then you allow the patient to be leading a normal life. Thank you for your attention, and thanks Hitesh for giving me the opportunity to teach the students.
Thank you, Rishi, for that brilliant lecture. You have covered almost everything, and I think everyone is going to get benefited really a lot. There are a few questions in the chat box. I couldn't find many questions, but I have a few questions. Rishi, if you can answer a few of them.
Yeah, Hitesh, I'd be happy to. Yeah.
Yeah. So, do you prefer a CT guided biopsy or an open biopsy for diagnosis?
Yeah. So there are 2 types of biopsies. One is the percutaneous biopsies, and another one is the open biopsy. So open biopsy is typically done when the patient is already been subjected for a surgery. So if the patient is presenting with a neurological deficit and you are already decided to debride the lesion, then at the time when putting the screws and curating the lesion, you send the biopsy. So this is called as a open biopsy. The second one is the percutaneous biopsy. In the percutaneous biopsy only, there is debate like whether to do a CT guided biopsy or to do a CM guided biopsy. So in our center, we prefer a CM guided biopsy because the first reason is it is under a very sterile environment. So we are doing it in the theater, and the patient is giving adequate amount of sedation as well as a local anesthesia. And in an image guided biopsy, you can use a wide bore needle. So we use almost a 8 French Jamshidi needle, which gives a huge core of tissue. And you can take multiple passes. You can go through the pedicle, into the disc, into the vertebral bone, and also the abscess also. The disadvantage of CT biopsy is the CT biopsy, they use a thin needle. And in the patient is usually kept in the CT console, which is not the best of the environment to take a sterile tissue. So that's why I don't usually prefer a CT guided biopsy.
Okay. Do you have an O arm to do a biopsy?
We have what we call as a CT navigation. So it's like an O arm, but the amount of radiation you get compared to a C arm is much higher. So this is like using like an AK-47 to kill a mice.
You just need to do a C-arm guided biopsy, right?
Yeah, that's the standard thing we do.
Okay. The other thing was regarding spine at risk signs. We know that there are four spine at risk signs like translation, toppling, retropulsion. And what is the real use of this? Is it that you have, when you see like two or more spine at risk signs, you intervene, you do go for a surgical intervention?
Yeah, absolutely. That's a very classical and very important sign which has been described about 20, 25 years ago by Dr. Rajshekharan. And because based on a 15-year follow-up study, they found some of these children who have completed the anti-tubercular treatment. So after taking 6 to 9 months of anti-tubercular treatment, they have been declared a disease-free by the government, by the treating doctors. And they followed them over 15 years. They found that some of these children developed real grotesque kyphotic deformities. The reason they found that some of these children at the end of the treatment, they had subluxation of the facet joints. So in all these four things, the common factor was subluxation of the facet joints. So if there is a subluxation of the facet joints, whenever there is an anterior defect, even after the disease heals, slowly, the child starts developing a kyphotic deformity. Because treating a kyphotic deformity in the healed stage with neurological deficit is one of the most difficult things to treat. I have seen a lot of children who present with neurological deficit, and it's very difficult to get back their neurology and correct the deformity fully. If you see at the end of the treatment or during treatment, if the child is having spine at risk signs where there is facet joint subluxation with one of the four things of four spine at risk signs, then it's better to fix the child then and there itself so that there is no further progression of deformity.
So I think facet joint subluxation is the key factor, right?
Yeah.
Is the most important one.
Most important. Yeah.
And the third question is about the formula that Prof. Rajshekharan did long back, y is equal to a plus bx.
Yeah.
So do you think it's relevant today, or is it concerned more with children or adults?
Yeah.
Prediction of final degree of kyphosis?
Prediction of that particular thing has not been validated in further studies, and at present what we follow is the amount of destruction of the vertebral body. So if there is more than one vertebral body involvement, either as a single vertebral body or 2 or 3 contiguous vertebral bodies are involved and each vertebra has like 30% destruction, then it amounts to 3 into 30 will be like equivalent to one vertebral body. So in that situation, we advise a surgery in these patients. At present, we don't use the y is equal to a plus bx formula.
Okay. And the other one is, what is your experience with multi-drug resistant tuberculosis and extreme drug resistance? Do you have a lot of cases in your hospital with these problems?
Yeah. So we have seen multi-drug resistance. Like I told, our incidence in our hospital will be around 5 to 7% because we try to do biopsy in all the patients and try to get a culture report before confirming the diagnosis. And MDR is usually, it's not as dangerous like what has been projected elsewhere. So if you have a good infectious disease specialist and based on the drug sensitivity, so once we get a culture report and we see 1 or 2 drugs to be resistant, we send the specimen for an extended sensitivity spectrum, and almost like 18 drugs will be checked. Based on that, we put the patient on anti-tubercular treatment. The second line drugs will be thing. The important problem is for the patient actually, for them to be on these drugs for a long time, that too with an injectable aminoglycoside for almost 18 months to 24 months is a difficult part for the patient. And we don't have seen any of these extreme drug resistance where it is resistant to every other drug.
Okay. So do you have experience using these new drugs? Like there are drugs like bedaquiline and delaminid. So these are some new drugs for extreme drug resistance.
Yeah. So I don't have any personal experience. So usually when we see such patients, usually we send them to the infectious disease specialist who takes care of the medical management. Till the patient remains as a primary drug sensitive tuberculosis, he will be under the complete care of us. Once there is an evidence of drug resistance, the infectious disease specialists take care of the chemotherapy part and we follow the patient as far as the disease healing is concerned.
Okay, that's great. And do you wait for the result of the biopsy, or suppose you're gene expert and CBNAT are positive?
Yeah.
Do you wait till the biopsy results are out?
Yeah, we wait for the gene expert. So gene expert, we practically we get it in 1 or 2 days. So the second day, the patient, by the time the patient gets discharged, we have the gene expert test, and based on that, we start the anti-tubercular treatment. If the gene expert also comes out to be negative, then we wait for the biopsy report, which typically comes in 7 to 8 days. Whenever there is a bone tissue biopsy, wait for 7 to 8 days. If it shows evidence of tuberculosis, we start an anti-tubercular treatment. If it is again negative, then we wait for the culture reports. Till the time the patient will be on empirical regular antibiotics based on, we'll be treating it as a pyogenic spondylolischitis.
Okay. So normally, how many days or weeks do you wait in case you're planning for surgery?
There is nothing like if the patient is decided for a surgery, then we don't wait even to get a biopsy done. So we straight away take the patient for surgery. And at the time of during the debridement, we take all the tissue and then send it for the 3 analysis. And initially, the patient will be on injectable antibiotics covering a broad spectrum. And once the results came, then we decide to convert into a patient of tubercular infection.
Okay, so that means sometimes you really rely on your CB-NAT and gene expert and not necessarily wait for the biopsy result if patient is sick. Is it right?
Exactly.
Okay. And because why I'm asking you this question, because we know that TB is the greatest mimicker or the masquerader.
Yeah.
So that's why I asked these pertinent questions, that whether we need to wait for the biopsy or not.
Yeah. So like I told, there are 2 aspects to this treatment. One is saving the spine and the spinal cord, and second part is managing the infection part. So when there is a gross neurological deficit, saving the spine takes precedence, and when you are fixing the spine, debriding the spinal cord, then at the time you take the tissue. When there is no such impending problems, then managing the infection takes precedence. You try to confirm the diagnosis, wait for the gene expert biopsy, and then treat the patient accordingly.
Okay, and is there a role for any intraoperative frozen section as you see in pyogenic?
No.
Not really, right?
Not really, yeah.
Okay, and I think a lot of postgraduate residents are there online for their benefit. Can you explain about spinal tumor syndrome and internal gibbous?
Yeah, so coming to the spinal tumor syndrome, so this is a terminology which was very popular in the days when we didn't have an MRI. So the patient had all features of a neurological deficit with the evidence of clinical features of spinal tuberculosis, but the X-ray didn't reveal any of the compression. There is no retropulsion within the spinal canal. And during surgery, they found out there is a abscess formation inside the spine, which caused the neurological deficits. So this was termed as spinal tumor syndrome. But with the advent of MRI, any patient who suspected having spinal tuberculosis, once he goes through an MRI scan, we'll be able to diagnose the presence of a intraspinal abscess much earlier. So this spinal tumor syndrome almost has become like similar to a scivora. Scivora initially used to be a bigger problem before the advent of MRI. Once the MRI had come, scivora has less importance. And second thing is internal gibbous. So internal gibbous is a thing which happens in children who has a healed tuberculosis, and over a period of time, when these patients develop a kyphosis, the bone which forms the apex of the deformity, at the apex of the deformity, the bone forms like a ridge, which slowly starts compressing the anterior part of the spinal cord, resulting in myelomelastic changes and a gradual onset of neurological deficit. So compared to the gibbous which we see outside, this gibbous which is inside and the anterior surface of the spinal cord is more serious, and it is called as internal gibbous or internal salient.
Okay, I think that was a very comprehensive lecture, and you have covered almost everything. And being from a center which treats all kinds of spine injuries and spinal tuberculosis, I think all our viewers have got the best experience.
Thank you. Thank you.
I thank you, Rishi, for sparing your time with us, and we look forward for more lectures from your side. And we're very glad that you have also been part of Orthopedic Principles as your spine section editor, and it has been a real honor to have you and also Professor Rajashekaran as our advisor. Thank you very much, Rishi.
Thank you. Thank you very much.
We'll end the meeting. Thank you.